Okay. Then please ask Director Yi to speak first. Explain to us. Okay. Dear Director Lu Xiui and Director Wang Ming. It's an honor to be with us tonight. Director Lu and Professor Wang Ming together. 3 people to share with you our experience with esophageal cancer surgery, especially thoracic laparoscopic esophageal cancer McKeown surgery. It's a classic procedure. Because esophageal cancer is in our Zhejiang area, it's a low hair. In particular, there are some primary hospitals. Because the incidence itself is not high, not many patients with esophageal cancer meet in a year. So you will feel that chest, abdomen, and neck surgery is more complicated. The scope of dissection is also very long. It's really wide, tough to do. And then there are some particularly high rates of complications, especially anastomotic leakage, even some rare gastrointestinal necrosis. If these serious complications occur, will be very troublesome. Then we're in the hospital. Maybe it's relatively speaking. Patients are more concentrated. There may be more than 300 cases of this in a year. We have to operate on such a patient, so we may gain some experience. I want to share with you our surgery. How do we make complicated, tedious surgery safe by simplifying it? Then the surgery went well. Let a regular thoracic surgeon do an esophageal cancer. Do 1 or 2 a day. I don't feel particularly tired. In that case, people may not be right. Esophageal cancer is still so repulsive. Mainly I want to work with Professor Lu Xiui and Director Wang Ming. And all the viewers online. Let's discuss and learn from each other. There must be a lot of flaws in it. Please give us more valuable suggestions. Let's make it easier later. Make it safer. There are fewer complications. This is our purpose, thank you. Then the following Director Lee can make some suggestions. Okay. I'm very fortunate to have Director Yi here today. Explain the experience of esophageal cancer surgery and share some surgical skills. Esophageal cancer surgery is the largest number of thoracic surgeries. At that time, it was also with Director Yi. Learned a lot of esophageal cancer surgery skills. Director Yi taught me a lot, including today's surgery. There may also be this one way, this stomach free. At that time, Director Yi sent a SI article. Specifically, this unique, fast way to free. And I learned a lot back then. So it's a great honor. Can you invite Director Yi tonight? Tell us more about it. Let's revisit and learn to consolidate. Ha ha ha. Then ask Director Yi. Let's go straight to the explanation. Okay, here we go at 1.5. Save time. We're a little tighter. So boobs. We generally start with the upper mediastinum. The esophagus, let's try to dissect it from the back first. Because we will later. You have the thoracic ducts. We routinely, 3 or 4 hours before entering the operating room, we've administered olive oil to the patient. When the posterior mediastinum was dissected, you can see a very obvious thoracic duct. This prevents damage to the thoracic duct. Surgery and secondary surgery. We operate on the chest dissection. We have a unique feature. Left and right hands are separated. We often do single holes. After we are used to it, it's all dissected through one hole. So our esophagus, left and right hands may be separated, will dissect better because the left hand handles it. After the structures around the esophagus grab, can pull the esophagus out with enough tension. Then make the electric hook in the right hand easy to dissect. Where is Director Yi's left hand? The hole between the ribs. The right hand is between the ribs. The 9th intercostal line at the scapular line. Reach in at that position. The angle that reaches out is the best. Left hand. Yeah. Left hand. The right hand is the operating hole, now the mid-axillary line end. The position of the 4th costal space between the posterior axillary line, then between the midline and the posterior line. 6th intercostal above the vertical longitudinal line. Just saw a smokeless retractor. Smokeless retractor goes in there. Pull these mediastinal lungs. It's like sticking in a little hands to give us more exposure. So let's longitudinal here and dissect to the top. We have a very large. It has been exposed for a long time because the right recurrent laryngeal nerve flows from the left. Subclavian artery bypasses here. We've seen the collarbone. The inferior artery has several branches. The molecule that takes the recurrent laryngeal nerve, we leave it out. Went around from behind. The nerve is the true recurrent laryngeal nerve. The root on the surface was electrocuted by me. The one that has actually burned to a point. It's the root of the recurrent laryngeal nerve. A branch from the mediastinal esophagus. The branch is not the recurrent laryngeal nerve. If you don't cut it, it will stretch and affect the anatomy. After we have gained experience, we knew it wasn't. Dissect it down there. The right recurrent laryngeal nerve follows the tracheoesophageal groove towards the subclavian artery towards the neck. Then we stick the recurrent laryngeal nerve end to dissect the inside of the tracheal sulcus, paratymph node of the right recurrent laryngeal nerve. Then it's very complete to sweep it down. Already dissected. So let's dissect the back of the esophagus. By the way, that thoracic duct is clear. I just saw a white one in the back, which is thicker. Now put the right recurrent laryngeal paranormal lymph node and the upper mediastinum next to the tracheoesophagus. A set of lymph nodes is removed together. Like this. We have the subclavian artery, the tracheal mediastinum, basically. The lymph is cleared. Is there a problem with the signal? The screen is gone. We are all fine here. Okay, it could be my signal. And then, next, after we dissect the upper mediastinum, after lymph node dissection of right recurrent laryngeal nerve, we are going to transect the strange vein bow again. We still routinely cross it now. We like to hit with white nails. I don't like hemlocks, because hemlocks are always foreign. It's not absorbable. Because after the gun is shot, just a nail. It seems to be more comfortable. The side of the strange vein on the outside, keep it shorter in order to make the test tube better exposed. The one on the inside can be left longer. This is good for the esophagus too. Exposure behind the odd vein arch. Otherwise, if that vein is hung out, will let you dissect, may block the view. When operating that directly, I think it's the left hand. Clip the esophagus a little more. After clamping it, pull as far as you can this way. Then the tension in the back of the esophagus is very high. We can just use an ultrasonic knife. After there is tension. This is a fundamental principle of anatomy in our surgery. Under tension is good for dissection. Blood vessels need more pinch points. Don't clip too little when the time comes. If there are too few pairs, it will be easily broken. Then when you pull it yourself, not so much power, add a little more. It pulls very well. Right. If the ultrasonic knife has tension, you can scan it. So here we have a little lymph node next to the left recurrent laryngeal nerve. Then lymph nodes. And here we are. We just sampled it and plugged it. Left recurrent laryngeal polynuclear lymph node. You can strip it whole and dissociate it. Then in the surrounding adipose tissue, take these together, but even if you are very attentive, you don't seem to have hurt him. In fact, after you are completely naked like that, there will always be some patients. It's still damaged by you. Postoperative hoarseness. So if we do this before surgery, when we MDT, imaging examination, if the left recurrent laryngeal nerve is not clear, then if there is obvious large lymph node metastasis, we can just take a sample. My patient has lymph nodes. It's early. CT. Yes, the patient is still a 2 zeros. So it was Tunsensurround before surgery. So let's forget about the lymph node sampling. Did not go to the whole bare left throat return. He had an endoscopy. Gastroscopy was also done. Endoscopic resection of the lesion. This patient is not. He is endoscopic and has never done it. I may have been wrong when I told you last time. No EESD. ESD didn't do it. We do the surgery directly because the patient is. Generally, this kind of thing should be a PET before surgery. This kind of thing PET routinely do. PET routinely do then. Enhanced esophageal scanning and now we have a radiology department. After discussing with us, decide. It's 3.0 of the esophagus. Evaluation of enhanced scanning of the esophagus. 3.0 T MRI dedicated to the esophagus. It is very helpful for the T and N stages of the esophagus. We have done it, shouldn't we? More than 150 patients. I did PET magnetism for a while. I remember the PET MRI. Right. So with the PET MRI, after the enhancement of 3.0, it seems to be more advantageous than PET MRI. So we will now become PET CT plus esophageal MRI. Do these two separately. Yes, I took the employee certificate. We also did a lot in the early days. To the back. I myself believe that no matter which esophagus, far away from the esophagus, you transect the esophagus. This is lower esophageal cancer. So we are on top of the strange vein bow. Transverse the upper esophagus first. After the transection, the esophagus is picked up. The back of the esophagus becomes the front. It's like pulling a scallion upside down. So the esophagus is free. You see, it's very labor saving. It is very time saving and very safe. Right. Then after breaking, while we wait for the esophagus to free down, you can also pick it up like this. Free from top to bottom. It's very, very convenient. This is a little bit of adhesion between the lung and the posterior longitudinal column. Give him a point. Directly. I see that your electric hook is used without bleeding at all. Any tips? Here's the trick. Many doctors may not dare to use it. What's the trick? That's me, the hook. It's our regular electric knife. The earliest use was an interoperable electric knife. That's an old electric knife. That's constant current. The electrocoagulation effect is very good. The electric knife is similar to that kind of electric knife. We use 75% of our energy. Normally, if we use an electric knife in the chest cavity, use 45. 55 has been used a lot. Using 60 is already incredible. We used 75. So it has a lot of firepower. When burned, it's very efficient. You see burn. Wait a minute, we can see the esophagus. Puncture those small blood vessels. Don't use too much tension when you hook it tightly. Don't burn it all at once, burn it slowly. These puncture blood vessels like this. We can all use 75. Electrocoagulation burns it at one time. I said under the strange vein bow just now. Superior margin of odd vein arch. Isn't there several blood vessels in that place? I think it's burned. It's all burned. Generally, an ultrasonic knife is required to copy it. Sometimes you don't want to change the ultrasonic knife. Then you use 75% electrocoagulation to burn it. I just see something thicker. Arterioles. Don't be so nervous. Let it burn a little longer. Let him be in touch for a longer time. And there are little blood vessels there. burning too fast. Then you go and make it up. That 75 is really powerful. You can put this ordinary small blood vessel. It's ha ha ha. Director Yi, you weren't like this before, were you? When did this start? I've been using electric hooks for about the last year. A year or two. In the past year or two, I have found that it doesn't matter if you use electric coagulation to increase it, as long as you, of course not such a large electrocoagulation, can't put the main images next to it. Don't burn the thoracic aorta. Burn right. But it's good to burn this little blood vessel. We show it well because I'm not afraid to show it well. I burned it desperately. Ha ha. The perfect patient. The gap is relatively tight. It can also work. Are you a little flustered? Yes. It can also work. I think it can be used when dividing the location of these tumors. Maybe you need to get closer to the hilum than these other than the hilum. These fibers, along with the surrounding tissues of the esophagus and the lymph nodes. Then it will be cleaner. People have adhesions, so there is an adhesion between the back of the hilum and the mediastinum. This electrocoagulation is indeed, it's like chopping melons and vegetables. Ha ha ha. Then these were originally tapped under these. You normally burn these small blood vessels, and there's a little vessel there. Yes, that's it. And then burn too fast. It's burning, but it doesn't matter. Let's press it with gauze. Then find the small bleeding spot and burn it. You don't need an ultrasonic knife too strong to get it. Original. These rumbling down. Bronchial arteries are numerous. If you say the electrocoagulation is not large enough, you can't burn. After burning, bleeding after a while, you will be bored. Then I dare not use it. I can only burn it with an ultrasonic knife. Right. So because of the coagulation hook, it works much faster than an ultrasonic knife. So, we are fighting for time, so we've been using electric hooks a lot since then. Of course there are some really big blood vessels. We still use ultrasonic knives. Director Ye's 5-claw retractor is placed between the ribs. 6 intercostal between midline and posterior line. And the fixed trench above. The 4th intercostal is above the same longitudinal axis. 6. Rib. Right. Wait a minute, we'll have a picture of that incision in the back. And then the person will lean forward a little bit. Right? Lie forward about 20 or 30 degrees. I didn't get to 135 degrees. Director Yi, I see that you are very accurate in finding gaps. If you have any tricks, please introduce them to you. There is a thoracic aorta to the back of the gap. There is a gap outside the thoracic aorta. Previous words. You dissect along the hilum. It's actually the pericardium inside. Wait a minute, you can see the heart. Complete pericardium. Then the pericardium cease. Outside the pericardium. Surgeons actually know. We have a concept for the facial space. Fascia gap. Last century foreigner proposed 1-by-1 membrane anatomy, a concept of a vivisection. Then you see there is a gap outside our pericardium. In fact, our chest organs, pericardial, tracheobronchial, arterial vein, esophagus. There's a gap around it. So let's say we do these organ removals. Like the esophagus, you can't dissect it along the outer space. Then those fatty lymph nodes other than the extraesophageal space. It's like we're upside down now. Pick up the trachea. Pull the green onion upside down from the top. Then along the outer space of the trachea, you see the bronchus. Ryu is clearly exposed. In that case, tumor of the esophagus. The most complete excision. It's the pericardium in the back. I'll keep the inferior lymphatic bulge. Wait a minute and scan it again. Would it be inconvenient? Right. That's along the outer boundary of the pericardium. If the electric hook works well, you just push. It will soon be above the diaphragm. In that case, the lower esophagus will only take a few minutes to pull the green onion. The method of pulling green onions is good. Yes, then. Smokeless retractor. We now move to the 4th costal clearance. Replace the electric hook to the 6th rib gap below, closer to the diaphragm foot, the place where the diaphragm machine feeds. We changed the ultrasonic knife. Position of the new diaphragm foot. Dissect it further. Sometimes there are some small blood vessels in the new Greek corner. That opposite is actually the lower lung ligament on the left is already there. Dissect all the way down the pericardium. You can see it. The back is the back diaphragm. It's basically coming out from behind the esophagus and surrounding tissues of the chest. Very clean dissection. And then we sweep away the subbulge lymph node, subcarina lymph nodes from the front just now. The mouth between the 6th ribs, upper 4th intercostal. Ultrasonic knife in the 6th intercostal. Walking with the trachea. The directions are basically parallel. Direction is favorable. Operation of subcarotid lymph nodes. The angle is at an angle to the trachea. You're going to scan the lymph nodes in the pit of the bulge. Operation there. There is one place where it is difficult. So, I purposely used the 6th intercostal incision setting to scan the lymph nodes under the faucet. It is the most convenient. I added a little blood in front of it. I don't bleed a lot. I ignored him. Anyway, the anatomy is still clear. Didn't stop the bleeding. We could have stopped it later. If I want to change the equipment, I'm not happy to change it. The main tube is too fluid. The settings of our incisions and the esophagus are transected first, and then pulled out upside down. I believe this plan is A. If it nourishes the blood vessels, it is also just right. Right. Very comfortable to sweep down. Like this. It's basically a rumble. Basically achieve subossification. Those blood vessels are particularly well handled. Any tips? This place. I dare not burn the electric hook. I might still use an ultrasound knife. Small blood vessels melt inside. If you experience bleeding, it's too dangerous to burn the electric hook again. The bronchi can be damaged. That could have serious consequences. And the position seam is not easy to sew. Rumble that place. I'm using an ultrasound knife honestly. That ultrasound knife uses that probe. You have to be careful not to burn the bulging membrane cloth to it. Yes. Maybe with a knife. A tiny turn. You have to be very careful. Have more experience. Okay. Sweep it away. If so, the operation on our chest is over. If you can do it like this, your chest surgery it can be completed in about half an hour, 27 minutes, including my opening credits. After the upper esophagus is broken, there is no need to connect it in the middle. I don't even have to use another way. Our abdomen is an incision in Director Donliger's abdomen. This is a classic laparoscopic incision. Make our classic incision for esophageal cancer. It's different from stomach cancer. Stomach cancer is definitely standing between the patient's legs. It also uses a smokeless retractor to pull the lever. The lever can also be suspended. Suspension, I think it will take time to sew it too. We make a hole in the non-smoking retractor. It will be pulled up soon. So we still use smokeless retractors. What is the location of this opening? We make a few incisions. It is 2 cm below the xiphoid process into the 5-leaf retractor. Below the navel, lower left, about a centimeter or 2 is the lens. Then the costal arch is the middle axillary line, and below the costal arch is the left hand. Then mid-axillary line below the costal arch and left of the navel. Between these two operation holes of the lower lens. The middle of an arc. It's the ultrasonic knife hole in the right hand. Midline of nipple. Near the navel, the position assistant near the belly button. Put a 5-leaf retractor in it, pressing our pancreas like this. Upper margin of the pancreas. We are going to open the retroperitoneum and then there is a paravartial lymph node. We open the common hepatic artery. The common hepatic artery is connected. In fact, it's related to the lymph node of the left gastric artery. It's all connected. Then the location is. It's easy to bleed during dissection. Use an ultrasound knife to dissect a little blood. It's pretty much avoidable. Be careful. Then the 7th group is to take the bulge. That's the root of the lymph node next to the left gastric artery. I also saw the left gastric vein. Let's not take it down completely. I let it stay there. Take it off with the stomach. It takes time to get it off. We are now saving time. Reduce operating time. We can use all the time we can save. This is a pararterial lymph node. The common hepatic artery is just below the lymph nodes. Its outer sheath has opened. This should be the position of the anus. If you go up there are arteries around the anus. That actually, the common hepatic artery and the anal proper artery are all connected together. Because it's swollen, we are trying to get rid of the lymph nodes. Finally got hold of it. It's not easy to catch. I can't hold it. I'm worried. And I can't clip it hard. It's broken and it's all blood. So you can only hold it lightly. So we're going to clamp on node number 8. Dissect it carefully. Be sure to use an ultrasonic knife. Can't do it without an ultrasound knife. The electric hook dare not be scalded. It may be easily damaged. Intestinal tract is still very good, but this location dissects. Sometimes it is easy to cause lymphatic leakage. We have also encountered lymphatic leakage becomes chylonic leakage. Chylous abdomen of the abdominal cavity. But most conservatives can do well. Okay, so group 8 lymphatic. 18 groups of lymph will be reduced. 18 groups of lymph nodes. In our patients with esophageal cancer, it actually has a very low transfer rate. I don't think it's necessary to scan sometimes. If the lymph nodes have metastasized, patients with esophageal cancer are late. Maybe you can scan the lymph nodes again. Not much value. So we all scan the left gastric artery. Parallel group 17 lymph nodes are sufficient. Then we put the upper edge of the pancreas. These structures along the posterior peritoneum and the left gastric artery. Push it all up again. We can see that the root of the left gastric artery is exposed. After being exposed, we are not going to dissect the lymph nodes directly at the root of the left gastric artery. Just short. I think shooting is the easiest and most convenient. Of course, with hemolux, the gastric aorta is so separated. And then out. That, of course, is a classic solution. But am I disconnected again? A little bit laggy, but okay. Am I disconnected? No disconnection, Director Yi. I can hear your voice. Yeah, I'm going back on. Then either Wang Ming, please stop first. Okay, I'm going to pause here. Why don't you restart it? Here it comes. Possible network problems. Okay, you can continue now. We keep going to the heart. Put the esophageal hole around the cardia. Open it further. After opening, we put the esophagus. The esophagus that was just transected is pulled down from the hiatus first. After pulling into the abdominal cavity, we'll start on the left side of the esophageal hiatus. From the cardia to the spleen. So I did it backwards. It used to be the last thing to do. We now call it a one-way operation. Or the other way around. Director Yi is stuck again. You pause and wait for him. Connected again. Ho ho ho, Director Yi. It seems that this network needs to be upgraded. It's good to see my network. Now from the cardia to the spleen. As you can see, the spleen can be seen very clearly. The left gastric artery is shown very clearly. I think it is a distinct spleen and stomach. An improvement plan. Let the dangerous part around the stomach, especially when the short gastric vessels are free, worried that the spleen will be damaged. We have since adopted the plan. The leather sheet has basically not been torn. Do half of the previous words. The skin is pulled off. I had to transfer it to open the abdomen and cut the spleen. That's a lot of blood. It's dangerous. Then if you do it after doing this upside down, put the most difficult left gastric artery, dissociation and dissociation of the splenic portal. Get rid of it first. Right. So I think the reform plan. Not so with laparoscopic surgery. A very good solution. There are a lot of problems, including the assistant and this in his hand. Front-end exposure methods. There are still places that have been doing it one way. That is, when and what kind of situation did it do with the big end side? Will it affect the plumber on the big end side? Divide over there. Usually we just rely on experience. After the big curvature of the stomach, don't hurt the right blood vessel in the omentum. Gastric omentum left blood vessel injury. It doesn't matter if you dissect it. We've done it before. We also sever 2 of the right blood vessels in the omentum. That would affect the blood supply. With experience, basically won't dissect that far. And then after we dissect this one near the spleen hilum on the large curved side, the location of the spleen portal, let's drift away a little longer. The rest of the greater curvature, it may be below the incision. A little bit of greater curvature tissue. If so, we add small incisions. It is very convenient when free. Okay, you see, a piece of gauze is fine. It's over. Remove it from the mirror. Just test this and get stuck. That is our incision vision. Then pull it out. We're outside. Make a small incision in the abdomen for a gastric tube. So the patient just now has the lower esophagus. It's the upper esophagus. That patient, we didn't film him in vitro, because the overhead camera is required to record it. That's another patient. He is above the esophagus. The middle section is still a section in the lower esophagus. The stomach tube pull out is different from the one just now, but the steps are the same. We pull the tube out. Okay, after pulling it out, the greater momentum of the greater curvature of the stomach, we solve it outside the body. Then pull it out. We big bends. We are drifting away from the laparoscopy. Then we are outside the body with the assistant. 2 people go to free greater curvature outside the body. It's more convenient. Yes, if you're under the endoscope, 2 people have to cooperate. Then the big bend is going to be in the omentum again. Outside the right gastric arch. Slowly use the ultrasonic knife in the body. It's definitely not as good as using an ultrasonic knife outside the body. It's very, very simple and convenient. This is the site of the big bend. Soon it will be dissected too. Then those great omentum just below the antrum. The stomach, the so-called gastrocolonic ligament. It's done outside the body. Anyway, the small incision needs to be made into a tube position. What can we do outside the body? Do it outside the body. It is also more convenient, faster and safer. Right. Laparoscopic thoracoscopy. It will be very cumbersome to operate. Laparoscopy in particular. So let's say there is a good simplicity. A clear plan to do it. That's certainly better. It's the backbone of the left retinal vessel. So we use hemlock. And then you have adhesions like this underneath the antrum. Lots of adhesions in the back of the stomach. And if these adhesions are present, if you divide it under the endoscope, it shows very bad. Right. If you pull it outside, difficult. Yes, I use manual words. Then it's easy. I was doing the laparoscopy just now. We opened the esophageal hiatus. Then the long section of the stomach esophagus is pulled out at the earliest. When we first started, afraid to open it, you all know that. It's the neck crack that needs to be opened last. Otherwise the carbon dioxide will escape. This was the conventional wisdom. And we tried, and we turned it on. So what? After the result is open, our laparoscopic procedure has no effect. Anyway, the one that flows to the chest cavity. The carbon dioxide escaped from the chest too. Influence cycle. Under abdominal operation, we don't think it will affect. Then we discovered the secret. Your esophageal hiatus can be opened first, it doesn't matter. It doesn't affect our laparoscopic operation very much. Someone in Director Ye's live stream asked about the stomach. How tinkerers ensure damage? That's what we were just under the laparoscope. Outside the body, I think it must be visible. That's your big curvature underneath the laparoscopy. When the splenic portal at the fundus of the stomach drifts to the greater curvature, don't wonder too much. Generally speaking, the first thing that you dissociate to are the branches of the left blood vessel in the omentum. Those branches you pulled up. It should be obvious at the time. Then the left retinal vessel. If you wonder, there are two. How long has it been since you left? You don't have to swim away from both ends anymore. If you are free again, it is possible that there are some branches at the distal end of the right blood vessel in the retina. You may be dissociated, so just don't wonder too much. Anyway, you can pull it out of the body and do it again. It doesn't matter. If the person is thick in fat, for example, it doesn't show very clearly. Is it a little farther from the stomach wall? It burned all the way. Yes. That is to say, the obese patient is between the fundus of the stomach and the spleen. Fat doesn't accumulate. Oh. So the solution is the other way around. Retrograde dissociation scheme. It is most suitable for obese patients. The omentum is not going to do it for him. The greater omentum, that's all fat. Pull around. By then, Lawler will be torn. It will bleed. Director Ye's patient is a little head high and feet low, right? Patient what? Do you want to put your head high and your feet low? Shake your head high and your feet low. Then let the flatulence and that. It's hanging down from the greater omentum. A gravity hanging down. Then we weigh shear war are like. Timon's place is easier. Yes, that would reveal better, yes. We routinely shake our heads and feet down. It may shake 35 degrees. 30 degrees is at least good. What is the general pneumoperitoneum pressure? 1,213 ordinary laparoscopic pressure. 121,314 I think is okay. That's okay. It's the esophageal bait route. Yes, yes, yes. Routinely do pipe positions with 2 nails. Join place. Let's add another break. Add an 8-character stitch. Reinforce it again. This is. Don't add it anywhere else. What to bury? Do we still use 4-0 prolines to sew continuously? Then get the tube right away. After the assistant tube of the abdomen is placed. When he does continuous sutures, we went to the neck to do the neck. Like this. After he sews the pipe, my neck and esophagus are also free. The mushroom heads of the stapler are also put away. So we start here with sequential suturing. That stitches me continuously. I don't take the time to wash it anyway. Then the neck while he is doing it, I put the cervical esophagus on it. Pulled it out. Because it's all routine. I don't have to show it all to you. It's the same for everyone. We went in through the anterior sternocleidomastoid muscle. Let's move the esophagus to the back of the thyroid. The back of the hypothyroid. A little above the hypothyroid. We do purse and anastomosis. Cervical esophagus. Maybe still leave a 3-4 cm match. How to prevent damage to the recurrent laryngeal nerve in the neck here? One of our key points is, after we found the cervical esophagus, this will soon enter the chest cavity at the top of the chest. After the thoracic cavity is entered, and you pull it out the back. After pulling it out, the esophagus is outward. When it was pulled very tightly just now, the outer space of the esophagus, to free the esophagus along the outer space of the esophagus. Like this. Left laryngeal gyrus of neck and neck. Nerves usually don't have access to it. Won't touch it. As long as you scan the chest. I didn't injure the left larynx. Then to the neck. Basically doesn't damage it. Because the recurrent laryngeal nerve in his neck is in the tracheoesophageal groove of the neck. The tracheoesophageal groove is equivalent to a very tense. In the case of dissociation along the outer space of the esophagus, then his nerves are generally untouchable. We don't do autopsies. Recurrent laryngeal nerve in the left neck. You don't have to go out of your way to show it. Okay. Ureters up. No need for purse pliers after the purse is done. Use our 2-0 Staxon or fishing hook line. 2-0 fishing line. Make a purse because the purse line is very reliable. You can tie the purse very tightly. You can tie it tightly at one time. The quality of the purse is good in this way. Anastomose. It's all a very complete circle. The quality of the purse is not good. It's easy to miss that. Therefore, the quality of the purse line is related to the problem that your purse can't be tied tightly. So we don't use purse strings. The purse line is a slip line. That slide line is sometimes not tight. You buckle hard, but there is no thread to buckle tightly. We cut through the esophagus vertically and then the mushroom head can be easily stuffed in. But there are some little women with thin esophagus. Then you still take the initiative to use 21. Otherwise, the esophagus will be pushed in and torn. If you tear, the anastomosis is dangerous. Right. That's the tube. It's the whole floor. Or plasma layer embedding. We are full floor. It's the eye of the needle. Sometimes it bleeds. It's all sewn up. Basically, there will be no long-term bleeding from the anastomosis. But it should be fine to embed it. It depends on personal habits. Many people do varus embedding. Not a full layer, or the whole layer will be embedded later. Then more carefully. Does the whole layer have the effect of stopping bleeding? Hemostatic effect, because it's all tightened after the whole process, so the whole process continuously. That long end, that's as long as the esophagus. Usually no problem. Okay, after the pus. The long end of the esophagus is very satisfactory. Keep less of the long end. Don't be too long. After too long, it will squeeze into the anastomosis. Let that anastomosis be a little bit. Yeah, the long section of the esophagus is stuck. The pipeline just mentioned. I'm not connected. Use a gastric tube with an inner core, stuck down from the neck. From the abdomen right in the esophageal hiatus. You can feel the stomach tube on it. You can pull it out after touching it. Good after pulling it out. You can touch it every time, right? Yeah, connect the tube to the fundus. Just bring it up again. Sometimes we used to pull wires. The line was accidentally pulled too hard. The wires are all broken. The tube position can't be pulled up. There is no way. I had to find a long one. Double-jointed soft dollar elbow. It goes from the neck down to the esophageal hiatus. That's really worried about the thoracic aorta. Just the gastric tube with the core can be touched every time. Sometimes it will be blocked inside and you will not be able to get down. Can't get down, I had to replace it with a harder one, like a size 22 chest tube. In this way, the chest tube with better elasticity can also be wrapped up. We didn't say it couldn't be stuffed because of it. It basically fits. Pull it up. Let's do the stapler anastomosis. It's very common to cut and then do an anastomosis. A large section of the fundus of the stomach needs to be cut off, so the remaining gastric blood supply is very good. The blood supply to the fundus of the stomach is basically normal in color. The blood supply is still good. It says something about the omentum. No blood vessels are well protected. No damage. It's just that an expert in the live stream asked how to judge the length of the tube position to ensure that the tension after anastomosis is not large. When you pull it up, it's loose there like this. The tension is definitely not too high because the stomach is also elastic. After you pull it up, you just need to let go of the top. The tension is definitely not too high. Just place the tube in the chest cavity, not there. Pull it tight. I'm sure the tension is just right. Sometimes the catheter disc is more troublesome in the chest cavity. It's more troublesome to play in the chest. A little bit laggy. Do you want to pause? Pause for a moment. Do you hear me? I heard it. I heard it. I pause. And experts ask, do you do a lot of manual anastomosis before the 3 leaves? Director Yi is back. Director Yi, can you hear me? Yes. We're going to pause the video for a second. Okay. The esophagus is lifted up like this. Is it possible to reverse it? When we pull it up, we need to put 10 esophagus in order. It's the side of the small band with continuous sewing on the side of the small band. Watch the little curve as he gets pulled up. Usually like this. Set the position and pull it up. Look in his small direction when you pull it up. Is it facing forward or a little to the right? Then it must be correct. Just say sometimes. In case you say pull it up, turn 180 degrees. The tube position is very long. Turn 180 degrees. It doesn't actually matter. But what the patient eats doesn't affect it. I twisted 2 patients. Eating is not affected. Okay. Then cut off another section of the fundus of the stomach. Cut a paragraph and stay. I left this tube very long because of his continuous sutures, and then it's down there. I cut it off against the top of the suture because it is in. If you step on it, the stitches are about to be cut. Then leave the stomach a little longer. Also very good. It can ensure the blood of the tube stomach of the anastomosis. Anastomotic blood supply is the best because its blood supply goes through the omentum at the bottom of the stomach. It's meshed like this. If you get too close, it could be that triangle. The blood supply will not be good for the place where you leave less. So we'd rather keep a little more. Then someone may be concerned. It feels too close to the edge of that mesh pot. It's all nails. One horizontal and one vertical. Right. The blood supply must be poor. More convection. Anastomotic vascular arch pass. The blood supply will be more, ensuring the anastomosis of the gastroesophagus. Anastomosis of the original kiss. Blood supply would be better. Then our place. We continue to sew continuously. Put the long end of the esophagus. We also need to do continuous suturing throughout the process. Then embed. Director Yi has an expert to ask, do you still do more hand anastomosis before the 3 leaves? Commercial signatures are manually matched using a scheme. It's getting faster. We do it now. Basically done it often before. But now there's less to do. We used to do stratified anastomosis. I didn't do it after 2 years. He's been using a stapler for years now, for saving time. After doing this, he will have anastomotic leakage. Stratified anastomosis, basically no leakage. Yeah, I was. Do you put 12 intestinal nutrition tubes after surgery? Or a single gastric tube? We routinely put jejunostomy tubes. So now we're doing an esophagoenterostomy. My assistant has put a jejunostomy tube in the abdomen. Because the video can only be, we routinely do jejunostomy. What is the appropriate length of the intestine? The length of the stomach I think is at least 3 cm or more. More than 3 cm. Blind N. After sewing continuously like this, after embedding it again, in fact, we will stay again, we wrap it in, go back slowly, such a blind N. Actually not so long. Because we have to stuff it back into the esophageal bag, then place, basically smooth. It doesn't mean that what you eat will escape to the blind N. You get a blind N syndrome. We have no phenomenon. There are still more blind ends. Because I'm going to stuff it into the mediastinal bed later. Stuff into the chest. Never mind. First the head is angular continuous, and then it comes back in. So the blind end of the esophagus, the possibility of long end releakage is extremely small. Right. Is the head you blindly holding facing your head and your feet? When we shoot, it's just to hit along the lever in the small intestine. Small intestine leash hits upright. Now the blind end of the stump, when you put it back, is its head facing the feet or the head? It's just stuffed back like this. It must be head on. Oh, the blind end facing up is still facing up. Some experts ask how to match. Make the anastomosis ring thicker and more uniform. Check the anastomosis ring when doing it yourself. The gastric ring is often uneven in thickness. We took the blind end that was typed out. It's the long end of the upper esophageal margin, that long end. I didn't take it out just now because we looked at N. A very complete circle is. It's very uniform. No problem. Because our purse strings are tied very, very tightly. The wall of the esophagus around the purse. It must have been completely knocked out. What was that suture just now? It's a visual line with 4 zeros. 4 zero visual lines. 4 zero visual lines. That tail is easy to pull off. Pipe position full layer continuous suture. The one who did the tube position just now. The line that does the tube position. What is the line that replaces the purse line? That's a fishing hook line with 2 zeros, or what we call dextral. So here are 4 zero micro bridges. It's reinforced. We are now reinforcing the original stability ones. I remember. Are you helping now? Reinforce a circle, right? Can reduce the incidence of leakage. We had more than 100 patients last year. The anastomotic leakage of the neck anastomosis is 3%. Still relatively low. And the missing patients. No symptoms after surgery. Even the neck incision doesn't need to be open. Leave that drain in the neck for a few more days. How many more days do you eat? Then the jejunal feeding tube lasts a little longer. Even that neck drain to bring back. You go home and get the nutrient solution. Neck drain. If the imaging is good, unplug it. You can eat that leak. In this way, if it's the leakage caused by the reinforcement, it's all a small leak. No serious consequences. Is the reinforcement full layer? Full floor? Some experts ask, does full layer continuous suturing of the tube position affect the length of the tube position? Does not affect. Okay. Because the pipes I left behind are enough. So the tube again. I think the length will be shortened. 0.5 cm has no effect, right? I'm going to pause here. This is an abdominal incision. Director E has an expert to ask, is it necessary to form a pylorus? We have so far no routine, but I think I should have done better, because after doing it, make sure the patient eats after surgery. There's no pyloric gastric emptying disorder after we do this. There are still a few patients who will have the problem of gastric emptying disorder. Of course, it gets better over time. The video is played at 1.5 times the speed. Then someone else asked, can the patient have a subarcuate anastomosis? Underbowel anastomosis is a single incision in the left chest, right? Generally speaking, esophagus, even lower esophageal cancer. Now do a thoracic parietal anastomosis. Even the neck fits are basically respected by domestic experts. If the efficacy matches, it might only work with shutter cancer. Director E, let me ask a question. That is, look at the holes in the abdominal incision. The observation hole is here at the belly button, right? Lower left of the navel. Is this under the umbilical cord? This went under the umbilical cord. Usually the bottom left. A little to the left. It's about a centimeter down on the left. Then my own ultrasonic knife is. Which hole to enter from? Just the top hole on the left. This is left-handed exercise. Equivalent to the midline of the left clavicle under the costal arch. Is the right side of the entrance. An expert asked when to remove the drainage tube from the neck. Neck drain. We have to 8 before pulling it out. How many days usually? Usually 7 or 8 days. And after day 7, we had them start with fluids of water. Nothing if you eat and drink well. You can eat porridge the next day. Good porridge. Sure, no problem. It's unplugged. Do you want imaging? We don't take pictures before eating. It is a consensus among domestic experts. It cannot be ruled out or very Is there an anastomotic leak confirmed? The verdict has been reached. Expert consensus has emerged. It will come out in 2 or 3 years. Oh, that anastomosis just now. A circle of reinforced spacing. What is the needle spacing? It should be about 1 centimeter. When will the jejunal nutrition tube be pulled out? Jejunal feeding tube. Our principle is early after surgery. Start enteral nutrition on the first day after surgery. After about the 5th day, total transition to enteral nutrition. All heat. Intravenous nutrition is not needed until after discharge. Because I just got out of the hospital 2 weeks ago, maybe even a month. Many patients still eat with their mouths or lose weight on your own diet. Maybe the weight is still down. We will make it clear to the patient the calories he ate after the surgery, equivalent to 1/3, 1/4, 1/2, 2/3 of what they used to be, to make a preliminary estimate. He just started eating maybe only 1/4 of the original. Then you also need to make up 3/4 of your total calories in a day. If you eat half your calories, then replenish 1/2 of the nutrient solution. And then when you can eat it all by your mouth, you can maintain weight without losing any nutrient solution. If you can even eat a little fatter, you can put the enteral nutrition tube again. This is how we guide. The patient uses enteral nutrition. There are also experts asking about jejunal fistula. Which is better than the nasal nutrition tube? Will jejunostomy increase the probability of intestinal adhesion? Will increase. However, this part of our patients' postoperative follow-up information is not yet available. We may have followed hundreds of cases recently. More than 500 patients are registered, I guess, after doing the jejunum leak. The number of patients with intestinal torsion will increase. But that means you need a second surgery. The proportion of patients is not high. What's the exact percentage? Because I have also encountered several patients in the past 2 years. Because the intestinal torsion can't be cured, it will be replaced by a second surgery. Oh, postoperative reflux. There is any way to prevent it? There's no good way. You can only raise the patient's upper body after eating, or upright position. Sleep at night to shake the upper body. It can only be like this now. And experts ask, after the neck drain is put in, do you still have the mediastinal drain? We won't let it go. Neck drain from the back of the anastomosis, along the front of the spine, all the way to the possible upper mediastinal thoracic roof. Neck drain instead of mediastinal drain, because if it leaks, it's from the anastomosis. Drainage around the anastomosis and drainage site. Smooth drainage can prevent mediastinal infection. Where is the end of the sternal canal? We put the observation hole. It's the hole in the mirror. Put it on the chest top. If the chest top is put on, we start from the neck to the anastomotic position of the incision. If you stick your finger in, you should be able to feel the chest drain. This way, the drainage tube is placed in the best position. How are the missed patients judged? Do you have a fever after drinking water? Or how to be sure he missed it? If the patient has a leak, the first time you drink water, the top drain will have dirty stuff out. This is A. Another patient will have a little fever. Then you tell him not to drink. You keep it open. Use antibiotics. His temperature will be normal soon. We call this leak a quiet leak. If there is no problem with drinking water on the first day, did you start a liquid diet the next day? It doesn't matter if you drink water on the first day. I often let patients eat porridge directly. You can eat half-stream food. When do you usually drink glycerin before surgery? Then how much to drink? 3 or 4 hours before surgery. Before being sent to the operating room, send it in because there is still anesthesia and there is still an hour left. About 3 or 4 hours before the surgery. Drinking more than 15 of olive oil is enough. 5100 ml is enough. An expert asked Director Yi, do robots do a lot? About what? The amount of surgery I have with the robot. About 40% of our surgeries. Because we robots use my surgeries a year, 130 esophageal cancers. Then there are about 60 of them. There's about 40 or 50 of them. About 50 robot test tubes. It's probably accumulated in total now. There are about 200 test tubes. The experience of robotic test tubes. Oh, an expert asked, it's these stitches you reinforce. What should I do if the one behind the anastomosis is not easy to show? How to sew? We try to pull down at one end. Just sew the bottom stitch. Pull it up again. This will reveal basically 1/2 turn. Pull the other side again and sew it down. Pull it up as much as possible. It can also be sewn. If the last 2 stitches may be apart in the back, it may be a little farther away. It will be 2 centimeters apart. But it doesn't affect the suture anymore. There are also experts asking about the postoperative anastomosis. Does the narrow proportion occur high? Not very high. Yes, there is. There are also patients who are not delicious. Then do the expansion. At that time, it basically did not affect eating. Not a very high percentage. That's an estimated 20%. I don't know if there is any. Maybe not necessarily. The bullet comments in the live stream are very active today. There are lots of problems. I keep reading. Is there any good way? If it leaks in the chest, maybe a neck drain. The location is not the most satisfactory. Thoracic drain. Also, if placed on the chest top. Generally speaking, it leaks into the chest cavity. Don't worry. Keep the water flowing. Strengthen anti-infection. Bacterial culture is a routine set of these. We use it. The product has good nutritional support. Generally speaking, it's no problem. But sometimes on the top of the chest drain wasn't high enough. The neck drain didn't put it around the leak. If it is not drained in time, it may form a Wrapping a fluid pneumothorax. Think of a way at this time. It's better to puncture him in the position of the liquid pneumothorax. Or how to put a pipe in it. Then rinse under negative pressure suction. If you drain it well, no problem, you can get better. It's going to be released under CT guidance. We often send it under the guidance of the ultrasound. That neck can be punctured without the blood vessels. Put a slightly thicker one. Pigtail catheters are okay. Because this is a small leak. Anastomotic reinforcement suture. Would that increase the incidence of stenosis? We feel as if there is no difference when it wasn't reinforced before. And the degree of narrowing after reinforcement. Nothing special. However, prospective studies may be required. Do a prospective randomized clinical trial that might prove. How long to take antacids after surgery? What medicine? Antacids. Antacids, I think. If liver function is okay, I think it can be eaten for a long time because after suppressing stomach acid, its reflux may be reduced a little bit. Then anastomotic ulcer. There are always patients. Go check the gastric tube. After the gastroscopic surgery, we'll report you a diagnosis of an anastomotic ulcer. Then the computer handles it. Anastomotic ulcer and erosion may reduce review. Some people didn't see it clearly just now. How does the tube position refer to the neck? Just say it again. That is, how did the tube position come up? The tube position is the neck anastomosis. That esophageal step. After the circular stapler is put away, we cut that one with a guide wire through the neck incision. The gastric tube from the neck incision along the posterior mediastinum. Wang Ming, please play the video again. Okay. Can you put it up? Our colleagues take a look again. Where did we do it? Along the neck, outside the body. Not in the thoracic laparoscopy. Move down. And then in the back, this is the abdomen. Further back. It's a leak from the neck to the back. Anastomosis. Look at the esophageal anastomosis in the neck. After putting the mushroom head away, we use a gastric tube with a guide wire from neck down. Then it is generally, if you're lucky, it goes into the esophageal hiatus. Then your hand goes from your abdomen to esophageal hiatus to touch the esophagus. Reach down. Then look at the hands on the abdomen. Yeah, stick it out. And plate it again. Hand in. Find the esophageal hiatus in the esophageal hiatus. I felt the gastric tube. Touch the head of the gastric tube and pull it out. If it doesn't work in the middle, change the chest tube. Yes, if it doesn't fit, you can definitely plug it with a chest tube. The chest tube is elastic. Very good. Not likely to escape to other places. Sometimes it's too long. Sometimes they flee to other places. I sometimes just put it all in it. If it comes over, it will also be sent to the discharge header. I can also pull it for you. Then do it again. Then you hold it up. Then who knows? Walk from the front to the back. Ha ha. In that case, pull it out. Usually in the posterior mediastinum. I have no problem pulling it up from the front of the lung. Not likely. Never been pulled in front of the lung. That place needs to be set up. Then pull up again. Hand in hand, give another give below. Then it will be better to pull it up. And then you do it. Will you put it again? Go down a little bit. I'll pull it again. Let it tube at the back. The mediastinum is straight in the middle and posterior mediastinum. It won't be thrown into the right chest cavity. Don't put it in it. If the plate is in it, it creates a cabinet effect. Causes gastric emptying disorders. Yes, yeah. To level it out. Still an important step. Director. Yes, neck anastomosis. It's attached to the neck muscle. Reduce anastomotic tension. Don't hang up. We just plug it back in completely. And then along the natural cavities of the esophageal bed. Don't go down the original position. Don't hang up. You take a shot. Every sip of water you swallow, the anastomosis is supported. If you support it 3 times or 2 times, it will leak for you. I told you not to hang up. It used to be said to fix the anastomosis in the neck, so as not to leak into the chest cavity, to fix it to the surrounding muscles. But I don't do it now. That way, the leakage rate is higher and it is distorted. Everyone's questions are very professional. Ha ha. Some experts ask how soon after surgery they start eating hard things. Is it possible to prevent stenosis? I would say in about 2 or 3 weeks. We are all 3 weeks later. You can resume normal eating. You can eat steamed buns. I often call patients. After surgery, I started to resume my normal diet. Eat 2 steamed buns a day. Dry steamed buns. Take a gulp. In this case, the anastomosis can be made, often subject to expansion. Then the anastomosis is narrow. Incidence may decrease. It's an ancient method. In the 1980s and 1990s, those old experts. That's why patients are called to prevent anastomotic stenosis. Eat it for half a year. Then he may not be very narrow. Ha ha ha. The more particular, the more narrow. It's not okay to drink soup every day. Leave director to trapezoidal anastomosis. Or what is triangulation? And a case on the Richter scale is legal. I think it's all a good way. Especially triangulation. It seems that TC anastomosis is a triangulation. Just those cases. Maybe still a single-centered or a limited number of patients. I think we need to prove its merits or the proportion that matches the occurrence of choler lower. It really needs to match the ordinary one. Do a multi-center clinical randomized trial. Then I think it will be better. It's probably the same as last time. I think it's a phenomenon. The esophageal bed and the posterior sternal path. What's the difference between the presternal path? Esophageal bed poststernum. The Japanese seem to use it a lot. Then there are many experts in our country who also do sternal posterior. Take the retrosternal channel. What's great about it is surgery. There may be much less reflux in the future. Because when we were in the right thoracic mediastinum, when our patient coughs, positive thoracic pressure on the stomach squeezes the most. It may be in the stomach when coughing. Things are easy to squeeze out, easy to reflux. But after refining the path, there will be much less reflux. Then the distance may also be shorter. But after finishing, will there be a little more leakage if the accuracy matches? But there was no randomization. Clinical trials to determine which is better. I think each has its own advantages and disadvantages. It is also said that some people are born with small stomachs. The tube stomach length is not enough. What should I do if the tension is high? You are a natural little tube person. Pull to the neck for anastomosis. If the tube length is not enough, I think it's almost non-existent. Because we all have a way to extend the tube position. The most common method is, you're much more free under the antrum. Then cut the lateral peritoneum of the duodenum. It's called cooking incision. Then the duodenum will also have a section lifted up by you along the tube position made like this. Then you make the tube a little thinner along the microband. In this way, the pipe position pulled up is. It's impossible not to pull the neck or your gastric tube. The fundus of the stomach is used to anastomose it. No gastric tube removal. At the bottom of the tube, you cut it down. Stratified anastomosis at most. That's also very reliable. There will be no problem with matching it. So this phenomenon I think is because the length of the free under the antrum is not enough. Causes insufficient antrum length. It's not really that the antrum isn't long enough. Dissociation is not sufficient. Free enough I could cut one do. You can lengthen it by another 3 cm, no problem. In theory, after subtotal gastrectomy. After subtotal gastrectomy, he pulls it up again if the efficacy matches. They all match. But pulling it to the neck may have a certain. That might not be very easy to do. I think your surgery was the best part. One is pulling scallions upside down. Inverted shallots. Then this patient is the middle or lower middle esophagus. Yes. So that's what we did in the upper mediastinum. Basically in the upper mediastinum. Begins at the superior edge of the odd vein arch. Cut it off. Its brother Ming, you put it in the place where the strange vein bow was severed. Transverse esophagus. Right. This is a transection of the esophagus. The position of the cross-section, just away from the tumor. I asked for a place. The margins of the precipitate should also be negative. I said when I made this place. The lower vertical grid below has not been divided yet. And then the back. When doing the lower vertical grid below, is separated from the mediastinum because of the front. So you pull the green onion upside down. It is particularly conducive to revealing. So the lower mediastinum at the back. This part of the esophagus frees especially fast. Yes. I think so, right? Because you see below, it was broken at the beginning. Yes. What if the patient has a tumor in the upper chest? Then I will break the upper and lower cardia. Right. So will the order of surgery be different? Let's do the order first. After the bottom is broken. After you divide down into the cardiac hiatus. Broken above. Lower esophagus. Pick it up. Pull from bottom to top. Then turn it around. That is to say, if the patient is a lower segment, we are going to start with the upper mediastinum. It's the same as before, right? Just that place. And then you get the lower mediastinum, and you get it right. Director Lee, if it is lower stage cancer, right recurrent laryngeal nerve in the upper mediastinum, lymph node dissection, the anatomical odd vein arch in the upper mediastinum, these programs are still the same. It's just that we cross. The lower esophagus may have to be transected first. Tell me, if a person is for example, esophageal cancer in the previous section, then the previous paragraph swept away these that should be swept away. But it's when you do the lower mediastinum. Lower mediastinum came out. Pull the lower esophagus up. Right. So like this. We pass the chest and abdomen like this. I think it's a slight modification. Let's make surgery simple. Because mainly it is revealed very clearly. Smokeless retractor I find very useful. Where can you do the smokeless hook? Like here in the rib cage. It pulls the pericardial hilar forward and then esophagus and thoracic aorta. The space between the thoracic vertebrae widens. Just expand it and reveal it later. And then we dissect it, and it's perfectly safe. Is there anything particular about the position of the smokeless pull hook? Just you do a better effect. He pulls it wherever you do it. Then you see where I dissect the bottom. He pulled it down. It's pulled to the side of the lung, or as close to the esophagus as possible. Get closer to the test to pull the lungs back. My left hand is called before CC. We pull the tube backwards. I'm going to pull the hook and push the lungs forward. The position is to create tension. It's very convenient for us to dissect. Yes, yes, yes. So smoke-free Legu is equivalent to us. It can help us show our surroundings at any time. Yes, yes, yes. Brother Ming, please put it on again. I don't know what happened. I didn't do this before. I don't know what happened today. Ask someone to do it again. Director Yi will help us talk about it again. It's from the place in Piemann. That one-way anatomical exposure. Okay. Wang Ming, put it on the laparoscopic part of the abdomen. Lymph nodes here. A little further ahead. Okay, here we go. Yes, yes. After the shooting in this place, the assistant continues. Press the part. Pancreas is exposed under pressure. Increase my exposure. Then my left hand takes the long end of the esophagus. Hold the long end of the left gastric artery for it. Bring it here and then, from the back of the stomach cardia, along the front of the diaphragm. To dissect and divide the cardia and part of the diaphragm together. The connective tissue on the edge of the hole removes it. For this around the hole. Around the esophageal hole and free it all away. If it drifts away, it will be connected to the chest cavity. The esophagus in the chest section is pulled out. Right. After pulling it into the abdominal cavity. What is this local assistant doing? The assistant now has his left hand. Turn the bottom of my stomach to the lower right. Pull the top right like this again. I see him on top. To the assistant, push my stomach. I originally asked him to bring it over with gauze. He's going to push it with the blunt-headed pliers. Then I asked him to put the gauze on top. Okay, a little more gauze. Stuff a little more. Gauze tuck in. Stuff it in the back of the stomach. Then lift it up. Now he's in jail. He goes up. There is still a lot of gas in the stomach, but it doesn't matter if we have a little gas in our stomach. Anyway, pick it up here. Put a gastric tube in advance. Now, for example, put in a gastric tube in advance. No gastric tube. Our gastric tubes all match. I'll put it after the tone is closed. Not bad at first. That place is the left hand prison. Hold it in your own left hand. Pick it down. Then you see the short gastric blood vessels. I can see it clearly, and I'll carry it for you again. It is very safe to slow down and burn. It won't burn. Okay, and then the short gastric vessels come in. If you are below, some of them may arrive. The small blood vessels that travel to the stomach from the left side of the omentum. It's basically just sticking to the prison seat here, right? Yes, it can actually be done firmly. It seems that the blood vessels keep it a little more. Let the omentum stay on it a little more. This is to prevent overburning. Burn to the right retina. Yeah, a little further away from the microscope. So as not to burn off the right blood vessel branch of the retina. That upper right omentum is sticking to the abdominal wall. He had rectal cancer before, had minimally invasive surgery. So it sticks to it. Originally these great omentums were hanging. I feel like you can do it from your stomach after removing this one. Right. It's not enough. You may not be able to carry it to that pinch. Your big curve car must follow it. It needs to be separated from that pinch. Therefore, the patient I'm going to go back a little bit. It's not enough to just go down here. At that time, the light came down from this side. Sometimes anatomical locations. The signature of this vascular arch. Sometimes it's not so good to reveal. Yeah. The little curved side of the stomach wall. The small curved side may not be pinched, and it doesn't matter. The big curved side may not be necessary. Don't clip it, because that needs to be done for anastomosis. That's your own hand clamping onto the little curve, right? Opposite small curve. Then pull it out. Others go to the omentum of the big band, and he will, turn my omentum against each other. Pull me away. The part of the omentum below the fundus of the stomach and the splenic phyla. It's the part of the omentum between it and the left colon. It was quickly divided. Don't divide too much. These are made by pulling them to small incisions anyway. That would be fine. That's about it. Right. Some experts want to take a look at this stomach treatment near the left artery. I'll go back and take a look. Left gastric artery including abdominal lymph node dissection. Please tell me more about this piece. So after you go in most cases, 18 groups of lymph nodes. In most cases, it is not necessary to scan because I think he's a bit big. So I swept him away. It's not normal to sweep it out. This local assistant. Press the pancreas down. Right. Then at the upper edge of the pancreas, the retroperitoneum needs to open it up. It is easy to get bloodshot after opening it. Yes. When you move it, it's a lot blurry and annoying. So the operation here should be very gentle. After dissection, you can see where the common gastric artery joins. And then skeletonize, the left gastric vein and artery. It's skeletonized separately. We're not skeletonized anymore. I want to deal with it in the most economical way. So take the left gastric artery I'm going to break. Just dissect it out at the root. I'm not going to dissect that much. It's useless to solve it or not. Just dissect the root. Dissect it out and shave the lymph nodes up. Shot under the lymph node. Just hit it. When the lymph nodes are also undergoing lung surgery, divide the lymph nodes distally. Then take a shot for the same reason. Right. The guns are all white, right? White nails, white nails. Okay, next to the common hepatic artery, so-called group 18 lymph nodes. It's called group 18 in esophageal cancer. Gastric cancer is called group 8. Adding 1 will change the abdominal lymph nodes of our esophageal cancer. Director Yi, you were talking about chylonic leaks. What kind of damage will it be? What's the cause? He just has some small chylous tubes from the surface of the common hepatic artery. Then we got hurt while dissecting. After the injury, he operated. When we dissect, you see the transparent lymphatic vessels. After seeing, we sometimes put a titanium clip on him. Close it up. Ultrasonic knives are sometimes said to be possible. It can also be burned and closed later, but it may also be closed unsatisfactorily. Surgery will still leak. Director Yi had an expert repeat just now. Asked about the location of the chest incision. Because the photo wasn't put in, I'll put it in later. Right, it's not in now. Now boobs. Did you knock out the vein this time? Veins may have been copied out. Because the left gastric vein can be burned with an ultrasonic knife, it doesn't matter. Director Yi, your chest incision is L-shaped. Let's talk about the incision again. Do you have an image? Image is not available now. I'll play it back and put it in. Oh. Not now. I'll send it to you from my phone. Send it to me on your phone. Okay, I'll send it to you on my phone. Play it back then. Thoracic incision, abdominal incision. Abdominal words. Director Yi, take the opening under the zipwa. It's a 5-claw retractor, right? The ultrasonic knife is under the rib garden, your separator, right? Under the rib garden. Then follow the mirror in the middle. Between the mirror and the incision under the rib garden, that opening is your ultrasonic knife. Then when you sweep here and turn it upside down, everyone be careful. Try not to burn it. There was no bleeding after the injury. Bleeding after surgery. That's a lot of pressure. Cut the blood vessel that left. Cut the blood vessel with the ultrasound knife at the bottom left. Is the hole still wider for him now? What is Director Yi doing with the hole? And widen the hole a little bit. Esophageal hiatus does not expand. I remember it used to be expanded. Make it bigger. How about being afraid that the place will be narrow? Previously, the tube position was widened. Relatively strong. In the past, the tube position was very wide. Ha ha. The current tube position is made thinner than then. I'm worried that the place will be pulled up. Now the guard is doing it carefully. I'll share the screen and change the picture. The video can't play that picture. I'll pause the sharing for a while. Okay, you find the picture. Pictures of chest incisions. Okay, now I'm sharing the picture of the incision. When taking pictures, I didn't take a picture of the person lying forward a little bit. Because you are standing in front of the patient to the left to shoot. It's like 90 degrees. He actually leaned forward. Like here. Between mid-axillary line and posterior axillary line. 46 is written here on the vertical axis. These two holes. It is the one on the left to put the smokeless retractor. A discharge hook or ultrasonic knife. The upper and lower holes can be used interchangeably. Is it the axillary front line? No, the front line is still ahead. A little between the leaves. It's actually between the midline and the posterior line. 46 on this vertical axis. Between middle and posterior lobes. Then the middle 8th intercostal. This vertical axis of the inlet. It's actually between the posterior axillary line and the scapular line. The posterior axillary line is further back. That means its hole is between the 8th ribs. You see right in the middle of the thickness of that rib cage. The median line behind the sternum is between posterior axillary line and scapular line. It's not the posterior axillary line. The posterior axillary line is very anterior. Then the left 9th intercostal. It's the scapulae, and it's actually a little bit later. Down below the scapular line. Is such a relationship. So I'm going to go back to the video. Assistants are all equal to. Your left hand is in the nineth rib, right? Yes, ninth intercostal. An expert just asked. Cleaning of the left recurrent laryngeal nerve. It's sweeping the left throat now. We only took a sample. Didn't show it all the way to clean it up. The patient was not clean. If it comes out early. Because the preoperative diagnosis is 0. So we took a sample. Our preoperative examination is on the thoracic duct. I am including PET-CT, CT enhancement and magnetic resonance of esophagus. 3 aspects to evaluate. If you say 0, it's possible for us to sample. But if you consider if left combined and reversed, there may be a transfer. Then we might have to expose it all the way. Clean up again. Has Director Yi ever encountered a colonic hernia into the chest cavity? McKeown surgery never encountered. Oh, I have encountered a single incision in the left chest before. An expert asked where the diaphragmatic artery is located. Diaphragmatic artery. The diaphragmatic artery was just seen. Now look at the diaphragmatic artery. Yeah, the one with the little bend. Connect up right. It's still very clear that it's all in there. Go up at all levels of the surface. Sometimes damaged. We had to cut it all off. Order to make it more secure. I'm going to burn it, or I'm going to call it a titanium clamp. I think the spleen in this abdomen is. The short processing of the stomach is the essence. Ha ha ha, this is really simplifying complexity. Right. It burned like this. That big pool sits on the side. It hurts that stomach. Why do you have to put in a gastric tube? Because the stomach is a little bloated. You can't stand it. The stomach is there and you can't expose it at all. Right. Why doesn't Director Yi need a gastric tube? Because he doesn't care. A little bloated stomach drags down anyway. Big and small, all. I think it's called the essence. Laparoscopy is a little easier. If we do this. Yeah, if the 8th lymph node doesn't scan it, laparoscopic surgery time. It can be shortened to 10 minutes. That's about it. Please make a simple summary. Then let me summarize. So tonight, it is a great honor for us Professor Lu Xiui. Take advantage of break time. Professor Wang Ming as the leader. Offer me the opportunity. And we asked each other, and we introduce ourselves. Let's put our little experience of esophageal cancer. Share hope with everyone. I hope you can give us your valuable comments. Not so many newbies to esophageal cancer. Let them do it more easily and safely. Esophageal cancer surgery can help. Thank you for your support and online guidance. Thank you. Thank you. Director Lee also invited you to speak. Thank you, Director Yi. When I was a young doctor, Director Yi taught me to make an esophagus. Relieved it again tonight. Review Director Ye's operation skills. Really, I learned a lot again, Director Yi. Although I have been for many years. I haven't had esophageal cancer for at least 2 or 3 years, but I learned a lot again tonight. I think it's thanks to Director Yi. Director Yi has been down for so many years. Exceptional esophageal cancer surgery skills. Too fast for over an hour. 1.5. No, it's 1.5 times tonight. Our live broadcast time is only an hour and a half in total. Everyone has to stay for discussion. Then the surgery time is 1.5 hours. And you have to roll over in the middle. Amazing. Ha ha ha. Does not include turning over. It takes 2 hours, including turning over. But the person who rolls over is slow. Thanks a lot. Director Yi can make time. Come and give us such a detailed and patient teaching explanation. Then I believe we can all learn. Everyone can learn from it. Can you solve some of your own problems? Anyway, at least I act as a member of the study together tonight. I have learned a lot again. I sometimes even now. Also started doing some esophageal cancer, to be honest. Sometimes a little flat. Now I feel like I can't do it without doing it. Rolled up again. Ha ha ha. Come. To carry forward Director Ye's surgical skills. Thanks for the compliment. Let's learn from each other. Okay, really learned a lot. It's on our own side now. Maybe a little more hand fit. That's basically doing manual anastomosis. Just take some time. I'm just a simple aspect of it. And I think the whole idea of surgery, including the order of operations, I think I still have to learn from Director Yi. I don't see anything else so far. The method is simpler and safer than Director Ye's method. That's what I think. Of course, you are also welcome. There are so many big coffees in the country, right? Everyone has their own skills. We can learn more from our teachers. We can grow more. Thank you, Director Yi, for your generous advice. Really learned a lot. I'm still quite emotional today. Director Yi is a novice-friendly skill. Not just newbies, I think. I'm not exactly a novice, am I? I can still learn a lot. Thank you so much, Director Yi. Where? I think our form is really good. Because there are a lot of details or something. It's our usual surgery live stream. You have also had a lot of live broadcasts or something. I'll explain it to you in the live stream, but there's no way you're going to pause. Do it, Director Yi, don't move. Tell me about the place too. That's impossible. It's better in our form. For teaching or for communication. It's the most thorough. Yes. That can be paused and played back. Repeated discussion. In the future, I will have the opportunity to ask Director Yi to talk about robots again. Director Yi is going to talk again in the next issue. A new posterior esophageal cancer. Prepare some materials then. We will ask Director Yi to speak a few more issues. See then. Okay. Thank you, Director Yi, for your wonderful explanation. Wonderful interaction with Mr. Lu. I believe you will have many new questions and valuable opinions. You can enter the comment area of the official account and live replay video comment area, or leave a message in the group of the Thoracic Surgery Network. You can also write a topic you want to explain in the comment area. Our fifth phase of the Big Coffee Online Surgery Video Live Broadcast Explanation. Tentatively scheduled for July 9th. It's next Wednesday night. Stay tuned.